So Dr. Lam gave me the task to talk about peritoneal carcinomatosis from the medical oncology perspective. And then I look at that and I was like, boy, where do I start? Because there's so many things that we can cover on it. So I'm going to do a little bit of a general approach, and then I'll focus mostly in colorectal, because where we have most of our randomized clinical trials data. These are my disclosures, and thank you very much for the opportunity. So let's just start as a definition, since we have different specialties joining us today. So what is peritoneal carcinomatosis? Actually is defined as a metastasis of the carcinoma throughout the peritoneal cavity. The peritoneum is a serous membrane lining the walls of the abdominal and pelvic cavities, and investing the containing of the viscera, and has two layers enclosing the potential space, which is the peritoneal cavity. What is interesting about when a patient has peritoneal carcinomatosis, that is presentation can really be very heterogeneous. You can have really just a small isolated nodes, nodes that you can see on the CT scan, or you're doing inspection, or you can have this widespread caking. And many times it's very difficult to image, and therefore it's really hard to assess the extent of the disease. So this is just an example what you can see in terms of omental caking and ascites on your, I guess that's your left. And then when you compare, for example, of the pseudomyxoma peritoniae, you can see that's a very different presentation, that you have this very jelly substance in the right side, just for you to have a sense of what truly is the peritoneal carcinomatosis. And this is a picture that can illustrate, if the surgeons is exploring, the cavity, what type of imaging they can see. Again, for the surgeons, as I'm sure, bread and butter, but for some of us that are not surgeons, this is important to understand. And why peritoneal carcinomatosis is so relevant? Well, the associated presentation can be really devastating. Patients can have bowel obstruction. They can have, therefore, a significant amount of nausea, pain, fatigue, and cachexia. And this is a picture actually from a paper from Dr. Lambert that showed this closed loop obstruction in a 56-year-old woman who had peritoneal carcinomatosis from a cancer that originated in the appendiceal. And you can see that this patient had, significant symptoms that had to undergo exploratory laparotomy and small bowel resection due to that. So it can really affect the quality of the life of the patients. So in terms of when do you see peritoneal carcinomatosis, particularly in colorectal cancer, isolated by itself without any other metastasis is actually about perhaps less than 10% of the patients. If you have resection of isolated mets, you could potentially consider this a curative intent approach. And the response to chemotherapy is a really important factor in the era of modern chemotherapy, whether these patients can potentially be taken to surgery to address the peritoneal carcinomatosis. Just to put you in context, this is an important paper that was published back in 2016, and you can see here that the patients that had peritoneal carcinomatosis, even if they have exclusively peritoneal carcinomatosis, the overall survival of these patients is very limited. Here you can see there is 16.3 months. If you have liver only, 19 months, and lung only closer to 25 months. And again, you can see in the graph the same. So emphasizing that this disease can be devastating to the prognosis of the patients, and bringing up the importance of why we should try to treat this disease. This is another retrospective studies that have been looking to addressing peritoneal carcinomatosis with cytoreductive surgery and HIPEC, which we'll talk a little bit later. And you can see in all these retrospective studies that despite the fact that on average, the median overall survival of these patients is low, we saw in the slide before, was about 60 months. If you develop a strategy to address that specifically, the median survival of the patients could potentially jump to more than 30 months. Granted, these are all retrospective studies that have been done on the subject. The first phase 3 study that looked into doing chemotherapy by itself versus cytoreduction in HIPEC in the colorectal population was actually done in Netherlands and was initially published in 2003, and later there was an updated publication in 2008. In this group of patients were randomized to receive just traditional chemotherapy versus the traditional chemotherapy plus cytoreduction surgery and the HIPEC. I must say that you can see a big difference in overall survival in these groups, and many can argue that in retrospect, perhaps this was just because at that time we didn't have many of the modern chemotherapies such as irinotecan and oxaliplatin. This study was only using 5-FU and leucovorin, but that starts to build the idea that if we address peritoneal carcinomatosis by itself, in addition to systemic treatment, we can potentially improve outcomes of patients. Before I jump to a few of the next slides, it's important to familiarize ourselves with few scoring systems that we use for peritoneal carcinomatosis, and we see that a lot in the reports. So we have the PCI report, which is European, that you score the abdomen in several quadrants, and you get your maximum score, which is up to 39. Did I got it right, Dr. Lambert? Yeah, all right. And then we have the American scoring system that takes into account the PCI, but also histology and clinical findings. That is called the peritoneal surface disease scoring. I'm missing one S on that. And why is this important? Because you can see here that depending on the scoring system that you have, the survival of these patients can be really impacted either by the PCI score or the PSDSS score. Either way, you can see that the survival of these patients can really vary if they have much more a volume of disease. Again, here it tells that the success of your outcomes is also dependent on the extent of the disease. And what's also important is that the completeness of the cytoreduction is really important. Patients that there is more than 2.5 millimeters of microscopic disease left, they can really have a jeopardized survival. And I think Dr. Lambert's probably going to touch on that in much more detail. So then based on all this, most recently in 2018, this phase 3 study was presented from the French group, and actually was the Unicancer, which was the use of HIPEC or Hyperthermic Intra chemotherapy for colorectal carcinomatosis. And Dr. Lambert is going to go into this much more detail, so I'm just going to give you a quick overview. Patients that had peritoneal carcinomatosis of colorectal origin and had a complete resection, then they were randomized to HIPEC or no HIPEC, just having the cytotoxic reduction. And then they will follow with chemotherapy for 6 months pre and post. And the primary endpoint was this study was survival, and you can see below here the stratification factors. These are the main eligibility criteria. Essentially, patients had to have confirmed colorectal cancer, macroscopic completely resection of the disease with less than 1 millimeter of disease left, and a PCI a score of less than 25. This is just what happens, the flow chart with the patients. You can see that in the end, they were fairly well balanced. This is the average PCI score on the patients according to the groups, was very well balanced. I think the completion of microscopic cytoreduction was well accomplished in most of the patients. I think I would assume that 90% is a good outcome. And you can see here also in terms of residual disease that the patients had. So mortality, in this study, the total mortality in 30 days was 1.5%, which actually was not bad. Sometimes when you quote the literature, you can quote mortality rates up to 5%. So actually the French group did extremely well. And the 60-day mortality was 2.1%. 6% as well. In terms of overall survival, you can see that the survival of the patients that have just the cytoreductive surgery were similar whether or not they got the HIPEC associated with a median overall survival of 41.7 months in both groups. And I must mention that I didn't show the slide, but the hypothesis is that just cytotoxic reductive surgery by itself, based on the literature, was going to be 30%. So these patients did extremely well, and the control arm was achieved much higher overall survival than was initially intended, or as the assumption was done. In terms of relapse-free survival, you can also see that the curves really overlap, but I want to bring to your attention that even in the end of the day, the overlap, you can see a little bit of a difference, particularly in the first year. So, you know, HIPEC might have some influence that doesn't drive necessarily later on a 5 years overall survival or relapse-free survival, but you can see that probably there is some activity. This was something that I'm not going to touch necessarily much, but just to tell you that, again, in terms of the PCI score that the patient has in the beginning of the surgery, they might influence how much the outcomes will be. And then there was this difference in the subgroup of patients that had a PCI score between from 11 to 15 that showed that the patients with HIPEC did better. I must say that this is a subgroup that we're talking, one group with 28 patients and another subgroup with 38 patients. So the numbers are too small to make long-term assumptions and change the practice on the patients, but this is certainly hypothesis generating for future trials. So the conclusions on this study was that the addition of oxaliplatin HIPEC on the top of cytoreductive surgery did not affect overall survival or recurrence-free survival. There was a little bit more post-op late morbidity in patients with HIPEC, which I didn't show the data, but there was a little bit more. And, you know, the curative management of PC with cytoreductive surgery by itself, it did extremely well. Again, we're talking about 17 centers in France who are extremely well, they were trained on this. Also, there's plenty of data that says the more successful a center is, according to more trained the surgeons are, and it has been well published on that. So where does it lead us? Does this study change practice? It's hard to say. The overall, these patients had a low PCI score. The average PCI score, even though they included less than 25, was about 10. This is still a small sample size. And some of the critics have mentioned that this study was using oxaliplatin, which many feel that might not be the same as mitomycin, which is something that we tend to use more United States. He also did a study use 30 minutes infusion that might be too short to demonstrate any benefits. And I think Dr. Lambert's going to touch on the differences between 30 to 90 minutes of infusion. They haven't been compared head to head, so we don't know if necessarily affect our US practice. And when we look at other studies, particular retrospective studies, we have some positive results with mitomycin. So I think more needs to be done on that. Oh, sorry, I was seeing at the wrong screen when was showing my bullets already. So what about the role of prophylactic HIPEC in after the resection of colorectal cancer, and why would that be logical? Well, it's a clinical problem, right? We see metachromatous peritoneal metastases after curative resections of colon despite adjuvant systemic treatment, and the rate of failure can be up to 25%, which is pretty impactful if you think about all the colorectal cancer patients that we see. It's also hard to diagnose this, and it's certainly hard to treat. So conceptually, you think that doing intraperitoneal chemotherapy to prevent the development of peritoneal metastases will make sense, and there's a lot of encouraging pilot studies that have been done. Because of that, in 2018, there was an abstract presented at GI ASCO that show the role of adjuvant HIPEC in patients with colon cancer at high risk of peritoneal metastasis. And this was called the Colorectal adjuvant study. Patients that were high risk for developing this, such as patients with T4 disease or M2 disease or a perforated colon, they were randomized to the resection of the primary tumor versus the resection of the primary tumor plus HIPEC, and then their usual systemic treatment. And then after 18 months, they underwent diagnostic laparoscopies to see the results. And this is just a different way to show you the experimental arm. And you can see that after the perioperative adjuvant HIPEC, they received K-Pox or FOLFOX for 6 months. In terms of the HIPEC chosen, it was oxaliplatin for 30 minutes plus the continuously intravenous 5-FU and leucovorin. The primary endpoint was a normal CT at 18 months, as well as the second look laparoscopy. And the estimative from the literature was that we will be able to see in the control arms up to 25% of recurrence. The sample size was to see a reduction in risk of 60%, from meaning the control 25% of peritoneal recurrence and the HIPEC group 10% of peritoneal recurrence. This is the flow chart of the study. You can see that in the end, most of the patients actually underwent the adjuvant HIPEC with the exception of 2. This is the characteristics of the studies. I'm not going to go into detail just for the sake of time, but you can quickly take a look here. And you can see if you feel like HIPEC really delayed starting of systemic chemotherapy, you can see that indeed when you just go straight for surgery and then chemotherapy, the median time to start adjuvant treatment was 6 weeks. With the HIPEC, obviously, as expected, took a little bit longer. That took about 10 weeks to start. This is the diagnostic laparoscopy at 18 months. And you can see here that, in the control group, peritoneal metastasis was detected in 9 patients, and in the HIPEC arm, there was detected in 2 patients. It was a small number of events, so there was really no difference in terms of experimental versus control arm. So the conclusions is that we didn't really see, at least in this trial, the superiority of adjuvant HIPEC with oxaliplatin at 18 months in patients that are high risk. We also noticed that despite the fact of treating these patients with systemic disease, we actually see overall failure of 21%, confirming that, unfortunately, prediction that we anticipated. And then the final study that I want to show is the Prophylactic study, which was a randomized phase 3 trial evaluating the potential benefit of the second look surgery plus HIPEC in patients at high risk of peritoneal disease. Patients had to have minimal peritoneal disease resected or history of ovarian mets or perforated colorectal cancers, and they all received 6 months of adjuvant therapy. And then if there was no signs of recurrence, they were randomized to surveillance versus a second look surgery with HIPEC. And then what is interesting is that in these patients that were taken to a second look, the rate of peritoneal metastasis was even higher at 52%, again, emphasizing how big is this problem. And the PCI score on the average of the patients was 4, between 0 to 26. Again, this was to some extent a negative study. There was no difference in peritoneal relapse between the group, either disease-free survival or overall survival in the patients. But it does confirm that, there's a high-risk population that indeed are very high risk to develop peritoneal metastasis. So we clearly need to do better to continue to be active and proactive in terms of addressing this disease. Here I touch mainly on the impact of peritoneal carcinomatosis in colorectal, but there are so many other diseases that there might be a role. And I will encourage everybody to take a look at the 2018 Chicago Consensus of Peritoneal Surface Malignancies. They have published consensus of many of the GI malignancies that might have be affected by peritoneal metastasis, including gastric cancer, neuroendocrine tumors, and appendiceal. And here I just listed one of the algorithms for gastric cancer that perhaps in a very selective population or patients, despite the fact that we don't have very solid phase 3 clinical trials, there might be a role for cytoreduction surgery plus or minus HIPEC in these populations. Neuroendocrine tumor is another group of malignancies that perhaps there might be a role. We really need more trials to address that better. But I would encourage everybody to turn to the 2018 Chicago Consensus, who Dr. Lambert is actually part of and had authored many of these consensus papers. And I think my take-home message is that peritoneal carcinomatosis is more prevalent than we anticipate, right? Sometimes I don't think about, right, as the main problem, but it is clearly, I think I have proven that it's very prevalent. I think multidisciplinary approach is the key to success. These patients should be discussed on tumor board. They should be seen by a surgeon with expertise. And, consideration for cytoreductive surgery plus or minus HIPEC should be given to a selected patient population in the right scenarios in the patient that is fit and robust for that. And again, probably after having, in general, the biology of the disease being shown that is favorable after some treatment with systemic disease. I think supportive oncology should be involved early on, exactly because of that initial presentation that I mentioned to you. This is devastating to patients, and we need trials. This is a unmet need that we have to develop better strategies. And for that, I'm going to plug in and advertise and let everybody know that Dr. Lambert indeed has a trial that's a little bit different, but is looking at intraperitoneal oxaliplatin in combination with systemic fulfilling for patients with peritoneal carcinomatosis with colorectal and appendiceal cancer.